the information is not really organized that well in this textbook. But whatever the case that is, chapter 8 is diseases of any organ system in the body that is not a part of the respiratory system. And then they have chapter 9, which is the respiratory system infections. And the reason for that is just because, like we talked about before in the previous chapter, the respiratory system is the most common portal of entry, and so that has the most diseases out of any of these. So they just kind of lumped all the other ones together, and we just kind of blow through them in this chapter. There is a lot more information in your textbook that's kind of just here and there. So what I'll say about this is similar to what I've said for the other PowerPoints that I did, and I didn't do it for all of them, but I tried to do it as much as possible. And I went back and added some highlights and notes today to try to compensate for it. Pay attention to the things that I've highlighted and the things that I have bolded, because these are kind of key features or unusual things or specifics about each of the different diseases that are things that you need to remember for each one. All right. So each one of these is going to talk about the diseases, the symptoms, the diagnostic procedures, and the treatments. I would say for the most part, your questions from these chapters are going to focus on the disease, the pathogen that causes the disease, its route of transmission, and its signs and symptoms. And I can't think of, I'm not going to say there's not one, but I can't think of a single question about a diagnostic procedure. And any of the treatment questions are coming out of the chapter 7 material that was the antimicrobial agents. There may be some overlap, but in here it kind of lists them for each one. I wouldn't spend too much time memorizing all of those from in here, because from my observations, those seem to be more in tune or aligned with the chapter 7 PowerPoint and material that we went through. Okay, so one of the terms that was related to a portal of entry was the parenteral route, and I put this on here because I always, when I first learned the term, I always mispronounced it, and so I put on the pronunciation on here. It actually has a link in the PDF for you to, you can go and listen to the pronunciation. But this is administered or occurring elsewhere in the body other than the mouth and the alimentary canal. So there was talking about a parenteral route that would be, we talked about if there's like a breach in the skin, if you get a cut or an abrasion or something like that, that would be the parenteral route. But there's also a discussion about administration of medicine via the parenteral route. So that would be either by IV or intramuscular or something like that, subcutaneous, anything other than the mouth or the alimentary canal. So I added that in there just to help myself and hopefully you. There are a lot of terms. Oh, I can't remember. I think I did. I think I did post in the week 7 lecture and 205 announcement a reply that has the week 7 key terms, or the chapter 8 key terms. So you want to also download that. There are also a ton of key terms, and I think there's a lot in here that are not listed on that key terms list. So anything that you don't know what it means in this PowerPoint, I would definitely look that up, because if you don't need to know it for the final exam, you're going to need to know it at some point here. And then this also talks a little bit more about the different types of transmission, the routes of transmission, and so you want to pay attention to that. So for the meningitis and encephalitis, this is what I was going to start with, this other image that I attached to the week 7 lecture in 205. We're going to come back to the blood auger here in a second, but this one is hopefully review from anatomy and physiology. Whoops, it's not going to let me do that. Okay, I'll just leave it this size. But I just wanted to pull it up just in case anybody hasn't taken A&P, or if anybody forgot, I wanted to just pull this up. So the difference between encephalitis and meningitis is where the infection is. So let me change the color just so we can see a little bit better. Let's do green. Meningitis, meninges are the protective layers that surround the brain. So this circle right here, or this square, that's not a circle, that is a square, showing these layers that surround the yellow is the brain tissue. Encephalitis is an infection of the brain tissue. Meningitis is an infection of these protective layers that surround the brain. And you can see it kind of blown up here. So you have your cerebrum would be your actual brain tissue. And then you have the pia mater, which is directly between the cerebrospinal fluid and the brain tissue. And then you have your arachnoid mater, which is the layer that's above the cerebrospinal fluid. Your cerebrospinal fluid is contained in your subarachnoid space, and that also has the vasculature that would also contain the blood-brain barrier in that area. And then you have the dura mater, which is the kind of thicker protective layer that's between that outer layer and your skull. It's your actual bone. So the meninges are those protective layers. So meningitis is an infection of these layers, including the cerebrospinal fluid. Encephalitis would be an infection of the brain tissue. And you can have both of these infections at the same time, so they can be overlapping. Meningitis can either be viral or bacterial. I was actually surprised to learn that the bacterial meningitis is actually a more serious infection than the viral meningitis. And I guess that has to do with your body's ability to fight off a viral infection eventually. But the bacterial infections, because of the blood-brain barrier, it is hard to get the medication to the bacteria that you need to. So signs and symptoms for meningitis are fever, rigidity, fatigue, headache, decline in mental status, and diagnostics can be a blood culture. You can also culture the cerebrospinal fluid. I think there was a question about that. I thought that had this highlighted. I can't remember if it's on the new version or not, but you can also do just a cerebrospinal fluid culture in order to determine the causative agent, or a lumbar puncture. A gram stain will identify if there's a bacterial infection, whether it's gram positive or gram negative. Transmission is via respiratory droplets. And then treatment is also via antibiotics. This is not the only possible route of transmission, but there is a question about it, and I think I might have added it on the next slide. Can't remember. Oh, yes. Okay, it's this one. There are, I think, like over 50 different viral types that can cause meningitis and 50 different bacteria that can cause meningitis. These are the most common organisms, and these are just for bacterial meningitis that were listed in your book. So it has the gram stain. I want you to notice this because there's a question related to this that asks about a viral infection, and gram stain results. Oops, that was the wrong way. Gram stain results are one of the distractors, one of the not correct questions. So anytime you see gram staining, you should immediately think it's a bacterial infection. So this is only for bacterial identification, would be the only thing that you use gram stain for. You don't need to memorize whether these organisms are gram positive or gram negative, whether they're cocci or bacilli. I just included it in this table just because it was in your book, but you do need to be aware of, throughout this whole chapter, the most common organisms that cause these different infections. So you want to just memorize these genus and species, and that will help you remember that, or help you with those questions. Just as a hint for your book, it makes a particular note about the fact that Neisseria meningitidis is spread by respiratory droplets. So the previous slide just said that all of them are, but this is one that your book makes a special note about there. So those are all of those different ones. And then this is common causes of healthcare associated meningitis. So these include these other different species that are listed here. And then, like I said, it has the treatment over here. There are very few questions, like I said, outside of the ones specifically in chapter 7 that we talked about that I highlighted that have a specific treatment that you need to associate with a specific organism. But like I said, so you want to think of healthcare associated meningitis. What are the most common organisms that cause those particular infections? And I hate it when I don't put the full species on there for these, but it's definitely in your textbook if you want to look those up. Or not species, that's the genus that's abbreviated. All right, so that was all meningitis. So that's infection of the surrounding protective tissues. Encephalitis is inflammation of the actual brain tissue. Similar symptoms. Additionally, seizures and paralysis can occur. Diagnostic is a lumbar puncture. Obviously, this can cause death if it is untreated. Again, I wouldn't focus too much on the medication. Causes of, this is the viral causes. So the other one was bacterial causes. This chart is the viral causes of meningitis or encephalitis. Again, like I mentioned, these can overlap and you can have both infections. Coxsackie and echovirus, which are considered enteroviruses. West Nile, St. Louis encephalitis, and Eastern equine encephalitis are spread by mosquitoes. One of the things that you need to pay attention to in this chapter, and I added all of these tables to these PowerPoints. So I think the original PowerPoints that are in Canvas, I don't think they had these tables in them. But these tables are from your book. Some of them I added additional information to, and some of them I did not. But any of these that I added in here, you need to pay attention to these distinguishing characteristics, like I said. If they're transmitted by a certain type of arthropod, for example, West Nile is transmitted by mosquitoes, you need to remember that. Mumps and measles, and then herpes simplex virus can also cause meningitis or encephalitis. And if, I don't know if you remember, actually we may not have talked about it yet, but herpes simplex virus is a virus that has that lysogenic or latent stage where it's not actively replicating and causing the infection, but where it resides when it's in that latent stage is in nerve cells. And so this is how it can travel to the central nervous system to cause these infections. All right, otitis media, AKA also known as earache. This is inflammation of the middle ear. Symptoms, irritability, ear tugging, decreased energy, appetite, fever, and vomiting. Can be treated with antibiotics, topical steroids, analgesics, NSAIDs, meringotomy. I don't even know what that is. Does anybody know what that is? I tried to look up everything that I didn't know today, and I totally didn't notice that one. It does also have the side note of no aspirin treatment due to the possibility of Ray's syndrome. Is that when they put the tube in the ear to let it drain? Is somebody looking it up for me?
It's kind of what I was thinking what it was, because they can't puncture it, right? They have to put the tubes in to drain it.
Yeah. Oh, it didn't save it right. I thought I copied the, now I don't remember how to spell it. M-Y. There we go. Yeah, meringotomy tubes. So that's what it is. Surgical incision into the eardrum to relieve pressure and drain fluid. Okay, that's what I thought it was. We were right. Got it. Yeah, so apparently, and I did some research on this because I don't know why, because I was curious. It came up in one of the classes I was teaching. But if you've heard of a burst eardrum, that it can heal back a certain number of times, but at a certain point, it's not going to heal back as well. So in general, when you have a nice clean incision, it's going to heal better than when you have a jagged burst of something. Anybody who's gone through childbirth probably understands that. I haven't, so I don't have personal experience, but learned it in my classes. All right, next one is parotitis. I don't know if I'm pronouncing that correctly. Parotitis is an infection of the parotid gland, which is one of the major salivary glands. And I put this in here because this is included within the diseases of the head and neck. And I don't remember, I didn't notice if this question's still on the final exam, but it was another question, but it had this as an infection of the digestive system. So just because it's a salivary gland, it's considered a part of the digestive system. So, oh, I think I have that in the note. So that's in the note. I don't need that. My nose is itching for some reason. Oh my gosh, I just redid this. Yeah, so I have that in that note. Can somebody tell me if you downloaded this updated version, can you pull up the sticky notes that I added in there? I just want to make sure that you can actually see them as well. Localized redness, swelling, you can just type it in the chat after somebody looks at it to let me know. Localized redness, swelling, firmness and pain, difficulty swallowing, high fever, chills. Because I added a bunch to this slide. Conjunctivitis, also known as pink eye. There's some lovely pictures in your book if you've never had pink eye or known anybody that did. Highly contagious. If it is just allergies or something like that, obviously it's non-infectious, but if it is bacterial or viral, it is contagious.
How is it transmitted?
Okay. As far as I know, it's contact. So if somebody were to rub their eye or something like that and then touch something and you touch it, I don't believe it would be airborne or droplets, but I mean, I guess if you were crying and somebody touched your tears, you could probably, but I'm going to say contact. If anybody wants to fact check me on that. Thank you, Mitzi, for letting me know the notes come up. See, I wish that I had this crazy, you probably won't be able to see it, but I had this crazy, let me see if you can see it. I was going to try to adapt it. I don't know if you can see it. Very extensive 4-page table that I made with our previous curriculum that had by organ system, the diseases, what their infectious agent is, what type it was, what route of transmission. And when we got the new text, I was like, okay, well, I'll throw that out the window because a lot of them aren't the same ones. So I wish the book had something like that, more inclusive or comprehensive, I guess is the word I'm looking for all of the diseases that it focuses on, because I kind of feel like it's all over the place with that. Treatment, bacterial will be topical antibiotics. Viral is going to be antihistamines and decongestants. And isolation, if anybody's ever had pink eye, they tell you do not go into work and do not go to school because it is highly infectious. Keratitis is inflammation of the cornea. That's that clear covering on your eye. This can be due to viruses, bacteria, parasites, and fungi. This was another one. I'm surprised I don't have it highlighted actually. This was another one that it was a most missed question from the final exam. I didn't look to see if it's on there again, but it was a question that was something to the effect of which of the following cannot cause infections of the eye. And it's actually, it might be worded the opposite way, but anyways, any of these. So basically any type of organism can be one that causes an infection of the eye. Diagnostic would be culture, bacterial. You would treat with antibiotics as usual. If it's a virus, you can treat with an antiviral if one is available. All right, so those were kind of skin and eye infections. Now we're moving on to an ear infection. Now we're moving on to cardiovascular infections. And endocarditis is when you have an infection of one or more of the heart valves. And signs and symptoms, I just included again in these little pop-ups any terms that I thought you may not be familiar with. So dyspnea is difficulty or labored breathing. Fever, edema is swelling of the legs or feet. Petechia is these small red or purple spots that can cause lesions or bleeding. And then the hair and nails is also possible. Diagnostic is an echocardiogram, where they listen to the heartbeat and kind of can tell better than just listening with a stethoscope, as far as if you have a heart murmur, if there's a valve leaking or something like that. Treatment is valve replacement or intravenous antimicrobials. Death, obviously, if not treated properly. If your heart's not beating, you're not going to live very long. Catheter-related bloodstream infections. There are quite a few, and I don't think there's any questions that have these crazy abbreviations that your book seems to love. But there's several of these that are more specific, referring to a certain type of hospital-acquired infection. So this is one of those. So this is specifically catheter-related bloodstream infections. And it depends on the infusion site or where the catheter is located, but they can be, if they're in the central, it can be the subclavian vein, the internal jugular, or the femoral. Signs and symptoms would be localized redness, purulent drainage, which is a thick, milky discharge from the wound. Yummy. Fever, hypotension, which is low blood pressure, change in mentation, change in mental status. Diagnostics can be blood culture from the catheter and from a peripheral vein. So there was something about this in the book, and I can't remember what it was. But it's basically making sure that you are not getting a contamination in your assessment of the culture in order to identify the organism. In peripheral runs, there's rarely infections. So they're more commonly in central areas. Oh, it's time for break. Well, let's take our first break. I was just about to say it seems like I've been talking a long time. That's why, because it's time for break. Let's break until 7 p.m. and then we will come back and continue on. So we will just continue on our journey through chapter 8. All right, so we finished off on catheter-related bloodstream infections. Okay, now we're on to infectious diseases of the skin and soft tissues. Oh, I was thinking the beginning was the skin, but it wasn't. Okay, cellulitis is an infection of the lower dermis and the fat tissue that is below that. Signs and symptoms are flat red area on the skin, difficult to distinguish border, possible drainage. They usually have slow development. Risk factors, non-intact skin. Remember we talked about the fact that most pathogens cannot penetrate the skin, so there's some type of breach in the skin. Chronic edema of the extremities, constant swelling in the extremities with extra fluid can cause infections to be more common also. Treatment is antibiotics. Erysipelas, which is a infection of the superficial layer of the skin. And it can also extend to the lymph nodes. Redness, swelling of the tissue above level of the skin, fever and chills, just normally has more abrupt onset and can also be treated with antibiotics, obviously, if it's a bacterial infection. Necrotizing skin and soft tissue infections, including necrotizing fasciitis. Does anybody remember or know what necrotic means? Necrotic tissue.
Deteriorate.
Dead.
Good. So that is dead tissue or tissue that has been destroyed by some type of infection. Gangrene is an example of that it has, and it like turns black and apparently does not smell very nice. This can be either serious rapid destruction of the skin or the fascia, which is kind of the connective tissue surrounding. Anaerobic can be anaerobic or aerobic. Edematus is swollen with excessive accumulation of fluid. Fluid-filled blisters at the site can even have fever, tachycardia, which is rapid heart rate, hypotension, low blood pressure, confusion, decreased urine output. Treatment is debridement and antibiotics. Debridement is removal of the infected and dead tissue, which is, I'm sure, not very pleasant. Okay, this next section, intra-abdominal infections. There's a couple of these that it has very specific signs and symptoms. I didn't really go through each question to see if these questions are on there again, but there's a question, or was a question on the final exam that had a specific one that talks about where it's radiating from and to. So you want to pay attention to these. This is why I highlighted it in there. So appendicitis is abdominal pain radiating from the navel to the right lower abdomen. Can also have nausea, vomiting, and loss of appetite. Treatment is surgery, appendectomy, antibiotics if required. And then acute cholecystitis is the presence of a stone blocking bile flow. Bile is the substance that is produced and released into your intestines by your pancreas that helps to digest fat. So this one has signs and symptoms of fever, your right upper abdominal pain radiating to the back or right shoulder. So again, kind of specific as far as where it originates and where it radiates to. Can also have nausea, vomiting, lack of appetite, onset of pain 1 hour after eating a fatty meal, which makes sense, right? Diagnostic gallbladder ultrasound. So your gallbladder is kind of your storage center for your bile. And so if somebody has a gallbladder removed, they just can't regulate the bile flow as well. Treatment, surgery, antibiotics if required. All right, diverticulitis is inflammation of the diverticula, which is the, trying to think of how to say it, like the little indentions in your intestines that increase the surface area so that you can ingest, so you can absorb more of the nutrients from your food is the word I was looking for. Rupture can cause a localized abscess and diffuse peritonitis, which is the tissue that lines the inner wall of the abdomen. And some signs and symptoms, pain in the lower left abdomen, nausea, vomiting, constipation, and diarrhea, and then treatments of antibiotics. Oh, here's our C. diff we were talking about earlier. Clostridium difficile colitis can be mild to severe, or it can be life-threatening. Very commonly with this occurs in somebody that has a history of antibiotic therapy 10 weeks prior to the onset of the symptoms. So the antibiotic therapy can decrease the growth of the other bugs, and can cause the C. diff infection to be more able to grow. Signs and symptoms: diarrhea, abdominal pain with cramping, lower grade fever, leukocytosis, which is an increased white blood cell count. And then diagnostics of symptoms and history of antibiotic treatment, contact isolation, and combination therapy. Which reminds me, where did I post that? I think I posted I want to say it was from the CDC. It's a C. diff kind of public service announcement flyer, fact sheet, whatever you want to call it. I think I posted it in the cafe corner. I forgot to mention this one earlier, actually, that I also posted. I think I might have posted it in the discussion also, but this is another post that shows all of the different factors that can affect how someone responds to a vaccine. I may have mentioned it, but if I didn't, this is in there. And then there's another one in there that impacts of cigarette smoking on immune responsiveness. Nope, it's not in there. It must be in the discussion board post. Anyways, it gives a lot of details about the C. diff infection. That one is a common hospital-acquired infection, so that one's also, I think it comes up somewhere else in our discussion also. Infectious diarrhea. There are several different ones with this. I included a table from your textbook on this one, but this is associated with the consumption of contaminated food, travel, or exposure to pets. There's a table that has the common food items that the different pathogens are associated with, that you're going to need to know the most common ones. And that's the one that I have the Kahoot for tomorrow that we're going to do at the beginning of class. But these are signs and symptoms: abdominal cramps, diarrhea that may be bloody. I think it's in here somewhere else, but I'll just put it on here now. Dysentery is when you have diarrhea with that's bloody or has mucus with the diarrhea. So I don't know why they didn't just put dysentery there, but generally that's what we refer to as the difference between diarrhea and dysentery, in case you see that. Treatment, self-limiting, really this is replacement of fluids is going to be the treatment. So it's basically just making sure that you don't have any organ failure from severe dehydration that is going to allow the infection to clear up. Usually food, not water. I don't know why it says that there, because it makes a big deal about Giardia lamblia being in water, contaminated water, and not food. So I don't know. Some of the things that are in these PowerPoints from your textbook, I don't know. Prevention, hand washing, cautious food and beverage consumption. Okay, here's the chart that I was talking about. So this is table 8/10, and I actually added, no, this might be in there. I can't remember. I think this is already in your book, but I highlighted it because it specifically says something about Giardia lamblia or whatever species it is, because they have several different names of them, but specifically being in contaminated water and not often in food, but then it lists it somewhere else as in food. So for your purposes, Giardia is in contaminated water as opposed to not in food. But these common ones, Campylobacter jejuni is often in poultry, unpasteurized milk, and meat. Salmonella, most commonly in poultry. I think I mentioned that earlier when we were talking about that. So you should always associate salmonella with poultry. Every single textbook I've ever taught out of associates those two. Shigella is commonly in milk and dairy products. E. coli is often in hamburger or produce. My mouse is not working correctly for some reason. Cryptosporidiosis is in contaminated water. And then norovirus or rotavirus can be in fecal oral contaminants. I may have already mentioned this to this class. I can't remember. I feel like my sessions all run together, and I feel like I'm saying the same thing over and over, but sometimes it's not the case. But when I first saw it, and I've had a lot of students are like, why would anybody eat something that has fecal matter on it? But if you are, scooping up the dog poop, scooping the cat litter box, changing a diaper, and you don't sufficiently wash your hands before you go to prepare food, that's how you generally get fecal oral contamination. Oh my gosh, my mouse is not working for some reason. I'm going to stop using it. Okay, genitourinary tract infections. So these are going to be the STIs or STDs. I don't know why they actually, I do know why. They started calling them sexually transmitted infections because the bacterial ones are treatable, curable, and they were trying to reduce the stigma associated with sexually transmitted infections, which I don't think it did that. But main thing you need to know for the sexually transmitted infections is what is highlighted in here, and then also know which ones are bacterial and which ones are viral, which I just noticed is not even on here for chlamydia. So I'm going to add that on here right now. So you need to just take notes if you don't already know that. But chlamydia is a bacterial infection, so it is treatable with antibiotics. Incubation period for chlamydia is 7 to 21 days. So it already has a long incubation period. And then on top of that is often asymptomatic. So even if somebody had a conversation about STIs with somebody that they were planning on having intercourse with before they did, they could talk about it. And if you don't know that you're infected, how are you going to share that information? So that's a major concern of spreading of chlamydia. And then in males, it's even more common to be asymptomatic, but may have painful urination, mucoid discharge from the penis. Or in females, you might have it kind of infect other areas that cause inflammation. So the cervix, the urethra, the fallopian tubes is this salpingitis, which I had never heard it referred to that before. So that means inflammation of the fallopian tubes. Endometritis, so inflammation of the endometrium. Oh, big thing about chlamydia. Again, pay attention to what I have highlighted and bolded. Chlamydia can lead to pelvic inflammatory disease, which can also cause infertility. So that's also a concern with chlamydia if untreated. All right, gonorrhea, also a bacterial infection. So again, treatable with antibiotics, although with gonorrhea, one of the things that you need to know is antibiotic resistance is a huge problem. For the most part, gonorrhea is resistant to penicillin because of the usage of it. I can't remember during which one of the world wars. There was a whole section on it in the documentary that I watched. I'm horrible at remembering history, so I apologize. But they used it a bunch of soldiers that were overseas that were having sex with a lot of the prostitutes and whatnot. And so they used the heck out of penicillin, and now gonorrhea is pretty much resistant to penicillin. Can also be asymptomatic. Diagnosis is PCR testing for gonorrhea. Okay, herpes simplex 1 or 2. This is a viral infection. So the three main, and I just noticed syphilis isn't in there, but the three main bacterial infections, STIs, sexually infected, is chlamydia, gonorrhea, and syphilis. And then your main viral ones are going to be herpes simplex, HIV, human papillomavirus, and the hepatitis that are sexually transmitted. trying to think if I'm missing any. Type 2, you can have type 1 or type 2. Type 2 usually causes genital. Type 1 is usually oral, but they can cross-contaminate or cross-infect. Can be asymptomatic or can cause blisters around the rectum or genitals, or obviously your mouth, will cause cold sores. These cannot be cured. There is treatment with antivirals that can decrease the shedding of the virus and the replication, but it doesn't completely eliminate the virus from the body. I keep grabbing my mouse. I'm going to unplug my mouse and put it away because it's not working. I keep grabbing it and accomplishing nothing. All right, HIV, obviously a virus. It's actually in the name. So immunodeficiency virus, if untreated, progresses to AIDS. So AIDS is the disease caused by the virus HIV and can lead to all kinds of opportunistic infections. I have on the next slide some of them listed, but like I mentioned, I think I mentioned it last week, anytime you see anything that talks about opportunistic infections in AIDS patients, it should pretty much be all of the above. Risk factors are having another STD, injection, drug use, receiving blood products, needle stick. Obviously, we know other ways. Sexually, doesn't even have that listed here, but that would be another type of transmission. Signs and symptoms similar to the common cold, infects the immune cells. Obviously, we talked about that last time. It infects your T cells. There are multiple antiretrovirals that can be used to treat it. Diagnosis is also PCR testing. PCR, I don't know if I mentioned to you guys what that is. I can't remember if we talked about it in a previous chapter, but PCR stands for polymerase chain reaction, which is basically, we call it amplifying the DNA, but it's basically just making a whole bunch of copies of the DNA so that we can test it with a sequence-specific probe that's attached to some type of indicator that's going to show us whether that is present. So kind of similar to serology and antibody-antigen interaction. But antibody is a protein that's binding to some receptor product that is like a key fitting into a lock. With the DNA, we can do that with the sequencing. So you have the adenine binds with thymine, guanine binds with cytosine. So a similar type of thing. You can also test for the presence of something if you have a specific genetic sequence. And then you have it attached to some type of indicator that has either a color or a fluorescence or something like that. This is just some of the list of the different infections that can occur with AIDS patients. So a bunch of different ones. This is not an extensive list. Obviously, there's a lot more as well, but I just wanted to show you an example of the range of different infections. Okay. Well, no, okay, we're almost done. We'll go ahead and finish this up, and then I'll put you in your breakout groups to work on your group discussion case study for this week. Bone and joint infections is, I think this is the last set. Osteomyelitis is one example where you have an infection of one or more bones in the body. You can have localized pain, redness, warmth, and edema or swelling at the site. You can have fever and chills. Treatment is debridement, again, removal of the damaged tissue. Antibiotics, surgery to remove the necrotic bone. Again, that's dead bone. So that would be if the infection is severely damaged the integrity of the bone tissue. Septic arthritis is when you have an infection in one or more of the joints of the body. So in your joints, you have, it just escaped me what it's called. You have fluid in your joints, and you can have an infection that goes into that fluids. Articulating, what am I thinking of? Anyways, if I think of it, I'll tell you.
Synovial fluid.
Yes, thank you. Synovial joints. Risk factors for this include diabetes, because a lot of times there is poor circulation in the extremities, and you can have swelling that, again, once you have swelling with a lot of fluid hanging around, you have an increased chance of getting an infection. Steroid use, surgery or trauma to the joint, rheumatoid arthritis, IV drug use, or advanced age. Signs and symptoms, you can have painful swelling joint, warmth at the site, fever and chills, and pain with the movement of the joint, obviously. Okay, this was another one that was a question that was on a previous one that it was just confusing the way the question was worded. So, diagnosis for a bone or joint infection a lot of times requires aspiration of the joint fluid or synovial fluid, like we were just talking about, for a sample collection if there is swelling. So we can test for the presence of all of these different types of pathogens that can be found in the area. All right, so that is just the summary. Yay, we made it through chapter 7. All right. My screen disappeared with everybody in it. I don't know why it does that sometimes. All right, does anybody have any questions before I put you in your breakout groups? Actually, I'll go ahead and stop sharing and then I can see everybody. So this is just for you to discuss your group discussion for this week. Again, week 7 is your last case study group discussion. I will put you in your breakout groups if you want, if you already have a system for it. If you want to say you do this and I'll do this and then we'll coordinate later, you can. If you want to stay on until 8 o'clock and work on it, you can do that as well. So I'm going to go ahead and stop recording.